So, very good morning, friends. Very good morning, friends. I'm doing this webcast because this is summer and many of you would have accumulated all your tonsil and adenoid. I usually start accumulating my tonsil and adenoid from December. Children who are indicated alone, who present with snoring, repeated attacks of sore throat, I advise surgery. So, and it's many days since I've done live, so I thought I'll do one live just for 10-15 minutes before I start my next case. So during April, May is the peak season for adenotonsillectomy. In fact, for at least 2-3 years back, I don't remember this many patients presenting with adenoids and snoring. Now, for the last year and this year, I'm seeing a very high surge of adenoids and even in children, because maybe there are three reasons. One is allergy is increasing. Second is inappropriate use of antibiotics. Third is biofilm formation, resistance to antibiotics, injurious use of antibiotics. People stop antibiotics after 2-3 days. So what happens is the adenoid becomes very big. The children present with severe snoring, and if you look at it, it's grade 4 adenoids, sometimes coming into the choana. So we generally give nasal steroids for at least 3 to 6 months. 3 months at least I give nasal steroids. And if the patient develops secretory otitis media, then basically we follow up for 3 months. And if it's not regressing, I don't do a grommet. I just do an adenoidectomy if there is an adenoid or an incision tubal dilatation. So today I'm going to show you one case of which I did today. We had 10 cases of
Sir, how is the patient, sir? Yesterday's patient, how is the pain?
Yeah, I will post it. Patient's pain is completely gone. Completely gone. I'll post the video.
Yes,
Okay,
I
now
have
I'm just going to share this video because many people it'll be useful. I'm just going to show you one adenotonsil. It's even though very small case, it'll be very useful for beginners because I have done the right side. I usually do it with coblation, and I will show you quickly how to operate on a tonsil. So basically, this is the plica. This is the plica, and you have to make an incision medial to the plica. So this is point number one. Point number two: divide the tonsil into head, neck, body, and tail. So always remember your grip on the tonsil is most important. Today, I asked one of my residents to do. He actually screwed it. He didn't know how to do a tonsil. After MS, they didn't know how to do a tonsil. Believe me, this is what is happening. And they get up in between and say, "Sorry, sir, I'm not able to do," or they get a false plane. So I'm just going to teach you some tricks how to start doing tonsil. Of course, I'll show you also dissection method, but today I want to show you coblation method. Now, again, I say this is head, neck, body, tail. So the tail contains the hilum. The body, the lateral part of the body, you have the paratonsillar vein. The head, so which part actually bleeds? The body can bleed, the hilum can bleed. So I'm going to show you where to hold it first. Use a valsalum. So I use a valsalum. I don't use the Dennis Brown. I use the valsalum, and I'm starting the formatting. Wait. Okay, now I'm going to share that, and I'm going to. This is very useful. Very useful for the youngsters. So I'm going to show you. So hold first. Where do you hold? You hold the neck. Don't hold the head. Hold the neck. See how I'm holding. So the first step is to hold the neck, not the head. The head is inside. So I make that incision and then push the. So this is where you get the plane. See how I'm getting the plane. So this is the plane. then that is the head. Head is exposed now. So that is nothing but exposing the upper pole, otherwise called the head. Then use the coblation. And then after that, see what I do. I hold the head. So first is the neck, second is the head. And then pull the head medially and make that incision medial to the plica. And then you can see that we are just making the incision and do pull this. This is the neck. I'm holding, no, sorry, the head, and I'm pulling the head medially. See the left hand. So the right hand is doing the coblation, and see the left hand. See, all these strokes are directed towards the tonsil. Very, very important, my dear friends. So don't direct it towards the fossa, you'll get bleeding. So then what you do is you just separate the head completely. Once you separate the head completely, that is the posterior pillar. See, everything, the whole step is done only with coblation. You see how many minutes it takes. Ideally, take around 2 minutes to do one tonsil, 2 to 2.5 minutes. See here, now that is the hilum. And I go towards the tail of the tonsil, and then I devascularize the tonsil. So that is what I do. And once you devascularize the tonsil, see my hold of the left hand. Very, very important. So this is all, see now, I'm coming just backwards. That's a posterior pillar. I'm coming backwards. So this is almost unedited video, and see how fast you can do. And whenever there's even a small RBC, try to coblate it before you remove the tonsil, or else you'll have to use the Mollison. See, that's it, finished. It's out. So 1.5 minutes. So after that, again, I tell you today, we did 10 cases like this, tonsil, and it took hardly around 2 hours to finish all the 10 cases. And of course, we are going to start mastoid now. I'll show you how to do the adenoid. Adenoid, very, very important, my dear friends. Many people do this wrongly. The adenoid, I feel, still they use the debrider, so many things, because debrider will bleed first. So don't use the debrider, use the cobblator. Coblation is the best. So one person is irrigating from above. You see, one person is irrigating from above and one person is suctioning from below. And you first make the incision. So you will see from below, I'm using a 70-degree telescope. I am making the incision here. Clearly, I'm making the incision. And please, please, please get the plane here. Again, this is unedited video. Unedited video, people say you will take a long time for adenoid. It's not so. See, I've still not got the plane here. This is the plane here. This is the muscle plane, perimysium. But now I'm revising my plane. So you have to, sometimes the adenoid due to repeated infection can be very firm. It can have adenoid stones also. I've seen many, many patients now having a lot of biofilm stones. And if you take a swab, they have various kinds of bacteria, even MRSA we have found. So I think nowadays the indication for adenoidectomy is becoming more and more pronounced. Pediatricians themselves are now sending the patient saying, please do adenoidectomy for this case. So another good thing is there is no bleeding. So even the age of the patient, you can reduce it to 3 years or even 2.5 years, because there is no bleeding. If the anesthetist says the patient is fit, the patient is having severe OSA and failure to thrive, you can definitely do it. You see how meticulously I'm doing it. And you see here, there is no bleeding when you do it from inferior. That is one important thing. If you do it from superior, that is because superiorly only we have periosteum, and there you have a lot of blood vessels. You will see that very clearly. Now, this is actually the plane. This is the perimysium, and this is the plane. See, try to get the plane. If you get the plane, you will not bleed. You will not have bleeding. The problem is in many people, what they do is they dig or they don't get the plane. See, that is the area where you find RBCs. You see, this is where you will find RBCs. And if you start from above, naturally you will have bleeding, a lot of bleeding. Here, when you start from below, there is no bleeding at all. You see here, there is no bleeding at all. And you are constantly irrigating from above. So I have not bent the wand. I have not broken any, tungsten, anything. See, this is Bond's wand. I love the Bond's wand for its power. If the same thing I use a different wand, it's very, very difficult for us to, control the bleeding. And try to always use a new wand for adenoid. Always try to do that. See now again I'm going down to revise the plane. The problem is they don't revise the plane. The plane. Again and again I'm saying you have to get the plane. If you don't get the plane, it will bleed. So it's the same with any surgery. If you don't get a proper plane, you will get bleeding. So now, see, this is a little bit of adenoid left behind over the plane. It can bleed, and these are all causes for, post-op hemorrhage, all that. So I make it a point that I clearly get the plane, and just now I did it around 5 minutes back, unedited, completely unedited video. I thought I'll post it for you before I start the next case, so that will be very useful for the we call it the summer camp. In our hospital, May month, you will have around 15-20 cases of adenoid every day, because for the past 1 year, I've been suggesting that if they are indicated, they will come. So if they have severe stoning, we try to give them a lot of conservative management. We give them steroid sprays, we give nasal douching. Sometimes even I've given deflazacort syrup for children. Even then, nowadays, they are not responding. And so it is it's a must that we have to do adenoidectomy. And people always sometimes claim, why do you want to remove it completely? Actually, I think last week alone we have seen a lot of revisions. We have seen revision adenoids and being done elsewhere with different instruments. Don't use curettes. Curettes are no longer the instruments of choice. For adenoids, you should never do it blindly. Always do it with a under visualization. This is very important. You see now, see how it's almost blocking the whole of the choana. And again, I just want to say that this is a grade 4 adenoid. Now, what I will do is I'll go up. I'll not dig from below, because it's this is where it's going to bleed. You see here that you can see RBC is coming up. So you see the movement, see my movements. They're all fast, quick movements, short movements. So between the eustachian tube, you are moving, and I'm trying to take off that big bulk. This is internal debulking. Initially, I did extracapsular. So around I went, but here I'm going in for internal debulking. So above, you can do the internal debulking, means you can go through the big bulk of the adenoid. But that is where you will have the big bulk, the superior part. Inferior, you might not have that big bulk. So you go for the internal debulking, means you remove it from above. Don't dig here. Periosteum will bleed. It's very important, my dear friends. See that is all a little vascular, and you can see here that I'm just moving it sideways. Never move it up down, because you might miss the plane. The plane is very important for adenoids. So this is very important. So here you can see that I'm almost going towards the choana. I have not even bent the blade so far. So some people bend it. If you bend it, what happens is you might have obstruction. You might have an obstruction of the blade. The blade gets blocked again and again. See here, you should not leave behind that tissue. I want to see the periosteum. So you have to see the periosteum. There's a lot of tissue here. And here is the fossa of Rosenmuller clearance. Always do the fossa, because now we are seeing tubal tonsil also. Recurrence of tubal tonsil. Believe me, I did last month, I did 2 cases of, recurrent tubal tonsil done elsewhere. Tubal tonsil had grown from sideways and blocked the choana. So all these presentations we are seeing, because some people are not willing to do that fossa of Rosenmuller dissection. So what happens? There is growth of, these are all lymphoid tissues, right? They will hypertrophy. Lymphoid tissues, hypertrophy. Yeah, correct. Of course, they're not malignancy. But if you leave behind a lot of tissue, see the periosteum. Now, I am now defining the periosteum. This is the periosteum of the basiocciput basisphenoid. I told you it bleeds in the center here. This is the center. There's a small vessel, and on either side here, you have a small vessel. Apart from that, you will not see any bleeding except when you go up. When you debulk, you might have a little bleeding. So center, you have a vessel right at the junction of the both periosteum. You have a little bleeder, but that has to be controlled by the blue. See that? That's what I'm doing right now. And now I have to examine the tubal tonsil. Tubal tonsil is one thing which nowadays, be very careful. If you don't go laterally, that is going to hypertrophy. So, of course, I don't know whether you're following up your cases. You have to follow up your cases and see how many cases you have a little bit of hypertrophy. Of course, it's very difficult unless you do a 2.4 mm endoscope and see maybe around a 5-year or 6-year-old child. In smaller, younger children, it's very, very difficult. Now, see here, that is the fossa of Rosenmuller. You see the clearance now. You see that's the perimysium, that is the periosteum. And now you have a little bit of lymphoid tissue here sitting right near the tubal tonsil. And what you can do is you can keep the blue. That's the eustachian tube orifice. You can see that's the eustachian tube orifice. You have not done anything to the eustachian tube orifice. You can see how clearly the perimysium periosteum junction is seen. This is the always examine the eustachian tube orifice also. And then what you do is you try to remove and delineate the perimysium nicely. See that all I'm revising. It takes hardly, this is an unedited video, it takes hardly 10 minutes for both adenoid and tonsil. You can count this, it's 11.45 minutes total with adenoid, with tonsil, it's 11.45 minutes. So I don't think it's too much of a time. If you use the debride, you will have a lot of bleeding. So that's it. So I just wanted to show you this is the final result. You can see what is the result here. This is the final result. Periosteum, perimysium. This is the longest capitis muscle. That's the eustachian tube. This is the salpingopharyngeal fold. You don't have to do anything to that fold. And that should be your final result. So I just wanted to show you this because you're going to do a lot of these cases during May, April. So thank you very much and God bless you. I'm going to start. We have a very, very big list. That's why I thought I'll just show in between a list. Are you ready? Shall I start? Okay. Thank you very much. God bless you. Are you happy?
Yeah, always, sir, with you. Yesterday, I only observed your case.
Yeah, I gave you the
Trigeminal.
link. The reason is because we don't have four-handed now, as I told you, because it'll be very smooth when I show it with four-handed. But it's okay. You saw that how we did it and it came out very well. Patient is completely, the pain is gone. I'll post the post-operative video also to you. Thank you very much.
Thank you, sir.
Again and again, I say, try to do the adenoid with pure coblation method.
I do coagulation only, sir.
Yeah.
Nowadays.
Yeah, very good, very good, very good.